So I'm going to talk about, so I have a subtitle to my presentation. So opportunities at the intersections, of which there are many, but today I'm going to focus on integrating mental health interventions for HIV prevention and care, primarily focusing on HIV care at this stage. This is who I am, and I'll start by just giving you a little bit of a background, and thank you so much for that introduction. I came in on the last part of that, Dr. Paresh, and I'll talk a bit about the global call to integrate mental health and HIV care. There's been a lot of energy around this recently. I'll share some lessons learned from integrating HIV and mental health interventions that we've seen in the literature, and some of which I've seen firsthand. And then I'll end by talking about a project that my colleagues and I are currently starting. We're still in the first year. This is an R01 from NIMH called Integrating a Transdiagnostic Psychological Intervention in the Care of Adolescents and Youth with HIV in Kenya. It's an implementation science study. So my early research experiences really started with this question of how can HIV and mental health come together. But I have to say that came about in one sense because I was very interested in global mental health and how do we think about mental health services in very diverse contexts? What can that be like? And for a very long time, there was really not a lot of investment in this area. We still have a dearth of investment in mental health in general and mental health around the globe more specifically. But if you go back into the mid to late 90s, there was much, much less than there is now. But what was happening at that time was that there was a growing HIV epidemic that was happening all around the world. It was and is a pandemic. And this was happening at home and it was happening abroad. And my early experiences in global mental health eventually led to this intersection of HIV and mental health. And I'll tell you a little bit about that. Soon after the new democracy in South Africa, that was in 1994, I was a resident, had my first trip to South Africa and met many people in the HIV community. We subsequently began to work with the Directorate of Mental Health and the South African Department of Health. They were very excited about the possibility of deinstitutionalization and really overcoming a lot of the systems that the apartheid structure had built in South Africa. But deinstitutionalization was happening just at this time when HIV had a relatively low prevalence in South Africa, but was starting to take off. Our work ultimately focused on developing training interventions around HIV prevention in partnership with the Directorate of Mental Health and collaborating with the government around policies that could make this work easier. I'll give you a quick example of that. One was the existing Mental Health Act when I first went to South Africa didn't really allow for people to talk about sex, to intervene around HIV in the mental health system. So you can see an example of a large hospital, which was the dominant form of care for most South Africans. The policy was confusing and made providers really nervous around talking about these things. And one of the interventions that one of my colleagues made, and we supported him in that, was to help to begin to work with our South African government colleagues around actually rephrasing the language around how do you deal with sex in the context of mental health services? How do you deal with intimacy in the context of institutional people who are living in institutions often for a very long time? And what should this look like in the context of a generalized HIV epidemic? I later went on to work with the International Center for AIDS Care and Treatment Programs at Columbia, where I was part of the Secretariat. And through that work, which came about after we were able to get HIV drugs to many countries, we began to think about how do we integrate HIV care into mental health services. And in Rwanda, the team there worked around integrating HIV care into tertiary mental health services. But even taking a step earlier, my first work was in New York City working with women with severe mental illnesses and HIV prevention. This grew out of the work that my mentor at the time, Ezra Susser, was doing with men living with severe mental illness who were at great risk of HIV. We learned it I think this is back in you can probably find a New York Times article on this back in the late 90s, mid to late 90s, showing that the prevalence of HIV in the New York City shelter system was tremendous. From what I can recall, it was something like 17% of men in some of the large shelters were HIV positive. And a majority of those men had mental health and substance use disorders. So Ezra was working with men, and I began to work around interventions for women living with severe mental illness, thinking about their vulnerability to HIV. What are the kinds of preventive interventions that we can develop when we take into account how does stigma affect women's relationship lives? How does having a mental illness affect their lives? And then how do the intersecting identities of being an immigrant, being a woman, being from an ethnic minority group, how do those intersect to influence risk? We developed a behavioral intervention, Ourselves, Our Bodies, Our Realities, that focused on women-controlled methods of HIV prevention, tested this in a randomized controlled trial. I was doing this work concurrently in New York City with the work in South Africa and eventually the work in Rwanda. And this kind of led me back to new work in New York City, ultimately focused on the mental health of African immigrants living with HIV. So all of these experiences really informed each other and launched me on what has continued to be an area of interest. And I'll just along the issue of HIV prevention among people with severe mental illnesses. In 2016, there was a nice review in the Lancet Psychiatry, having a look at what was the global data around these issues. And again, you can see from this, there were a number of studies from North America, fewer studies in other parts of the world, but the takeaway from the North American data, I think, which is important, is that, and now I think we would say that that prevalence ranges from 2% to 6%. But regardless, it's significantly higher than the prevalence of HIV in the general population, and shows that in general, in places that do not have a generalized HIV epidemic, people with serious mental illnesses are quite vulnerable and more vulnerable than others. That is also true in some other settings. This is more recent data from Botswana, looking at the HIV prevalence among 955 people hospitalized with a mental illness, and specifically noting that there is a gender effect here. Among these women, among these people, there was a much higher HIV prevalence among women with a mental illness compared to women in the general population, and of course, compared to men who are also hospitalized with a mental illness. So that's all I'm going to say about prevention. But I always feel like this is important to think about, especially when talking to an audience of people who are caring for people with serious mental illness, just reminding us that these are important questions to ask, ensuring that we understand people's relationship lives, the vulnerabilities they may have is a part of our psychiatric care. So I'm going to shift now to thinking more broadly about the call to integrate HIV and mental health. Data from the Institute for Health Metrics and Evaluation estimates that around 970 million people live with mental disorders, around 161 million people live with substance use disorders, and UNAIDS will tell us that roughly 39 people live with HIV around the world. And I typically say to people who are HIV providers that if you have not seen someone with a mental health condition, then clearly there's an issue with screening. There's something that is likely missing, because I don't have to tell all of you, but mental disorders are quite prevalent, and that prevalence of these conditions is true in settings around the world. People living with HIV have a greater risk of mental health conditions, and part of that is due to the neurotropic qualities of HIV, living with a chronic life-threatening illness, and the social and emotional sequelae of that, but also exposure to social adversities that bring intersecting risk for mental health conditions and HIV. I'm going to talk specifically about depression for a few of the next slides, because that's the most prevalent condition, and that's probably the most studied condition. We know that comorbid depression and HIV quite common. Predictors include female gender, older age, unemployment, negative life events, childhood trauma, and a greater number of HIV-related physical symptoms, low CD4 counts, impaired function, and poor social support. Some of the consequences of depression in HIV are barriers to HIV testing, poor adherence to care, attrition from care, higher mortality, and increased sexual risk behavior. I'm going to tell you about two studies specifically that have been looking at the questions around mortality and depression and HIV. Brian Pence and colleagues found a dose-response relationship between the length of depression and HIV-related outcomes. They looked at nearly 6,000 U.S. individuals living with HIV and found that for every increase of 25% days with depression, there was a 19% increased risk of mortality for this population. My colleagues and I asked the same question through the African cohort study. And this is a study of people living with HIV and some people who are not yet infected with HIV living in Kenya, Tanzania, Uganda, and Nigeria. And we wanted to understand what was the risk of all-cause mortality among adults living with HIV who had depressive symptoms. So in this particular analysis, we looked at around 2,500 participants who were enrolled between 2013 and 2020. The majority of them were women, median age of about 38. A majority of them were virally suppressed, so this was not the driving factor, and about 18% had possible depression defined by a CESD score greater than 16. And our study we found something quite similar to what Brian Pence and his colleagues did, but the risk was a bit higher, that for every 25% increase in the percentage of days a person lived with depression. So this is looking at how much depression are people exposed to over time with repeated assessments. This was associated with a 69% increase in the risk of all-cause mortality in this particular population. So what we do know about HIV and mental health is that there's a bidirectional relationship. If you start at the top of this figure, many of the same determinants that drive HIV risk also increase risk for mental health conditions or for substance use. These include social exclusion, violence, discrimination, poverty, which can also lead to behaviors that can increase HIV vulnerability, as well as increase stigmatization, and often lead to behaviors that are criminalized, thus increasing the risk for exclusion and social marginalization. Groups at most risk for HIV are often more vulnerable to mental health conditions, as I mentioned, and we see the same vulnerability to HIV infection often among groups of people living with mental health conditions. So these relationships make integration very important, and they also underscore the importance of simultaneous efforts to reduce discrimination, criminalization, and to address the social determinants that drive risk. On the right-hand side of this diagram, you can see integrated responses. So it's possible to screen for mental health problems in the context of HIV care, also screen and test for HIV in the context of mental health care, treatment, and blending and integrating treatment, psychological interventions, pharmacological interventions can be delivered in HIV care and treatment settings. Similarly, HIV drugs, ART, can and should be delivered in mental health settings when people are HIV infected. And these things can lead to decreased risk. And finally, at the bottom of the slide, integrated care, we hope, leads to reduced vulnerability, improved adherence to prevention, treatment, and care, as well as to linkage and retention in HIV care. What's notable over the last, I would say, 5 or 6 years is that this issue of how important mental health is to HIV, for people living with HIV, and to the course of illness when people are living with HIV, has been taken up by UNAIDS, has been taken up by the World Health Organization as well. In 2018, I was really fortunate to be working with UNAIDS to develop this background guidance paper for their biannual meeting of their program coordinating board. So this was the first time UNAIDS had put together a document focused on mental health and HIV. This one focused on, we wrote about promoting human rights, an integrated and person-centered approach to improving ART adherence, well-being, and quality of life. So this was launched in December of 2018 and had a very positive response. Shortly after that, UNAIDS published its HIV 2025 targets. And you'll see that what's interesting in these, in addition to the typical 95, 95, 95 targets around identifying people living with HIV, ensuring that people are linked to care, ensuring that people who are on care are virally suppressed, the 10% and 95%, these new targets also included addressing some of the social drivers of vulnerability for people at risk for and living with HIV. So by 2025, less than 10% of people living with HIV in key populations would experience stigma and discrimination. Less than 10% of people living with HIV, women and girls in key populations experience gender-based inequalities and gender-based violence, and less than 10% of countries have punitive laws and policies. On the other side, we have the 95% of people at risk use combination prevention, the 95s in HIV treatment that I just discussed, but also that women have access to sexual and reproductive health services, that there's coverage of services for eliminating vertical transmission, and that 90% are receiving preventive treatment for TB as well. And then the final 90% is that 90% of people living with HIV and people at risk are linked to other integrated health services. And this is where mental health services come in, as well as other kinds of social services, substance use services, harm reduction. All of these fall into this bucket. In early 2022, we published this document for UNAIDS that brings together recommendations for how you would begin to implement this. If you are a country that says, you know what, we're a national AIDS program and we need to figure out how to start to bring mental health care into what we do. We need to figure out how to start to bring harm reduction into what we do. I worked closely with UNAIDS and to develop this guide, Integration of Mental Health and HIV Interventions, Key Considerations, which we have been working to disseminate widely to countries as well as programs that are interested in this kind of integration. So a lot has happened around integrating care recently. I think the first question when we talk about integration is, what do we mean by integration? So integrated care can have many meanings, including at this first level of clinical and community integration. And so it requires considering the structure of care. Will integration happen through co-location? Will it happen through integrated provider networks or organizations? Or will service delivery systems be fully integrated? So this level 1 is saying, how do we have clinical and community integration? Level 2 is, can we have integration of what professionals do? And at level 2, I think a good example of, and level 3 is really thinking about service delivery systems. How do we ensure that this could be at a district level, at a county level, that we're integrating these kinds of systems. But another good example of integrated care is the collaborative care model or team-based care model. So integrating care using caseworkers, integrating care so that we have non-physicians coordinating care, and then developing integrated care plans for HIV, for mental health, for substance use, and facilitating referrals. So these can be peer-led, they can be primary healthcare worker-led, elements of this can be mental health worker-led, and the flexibility, I think, is what's helpful depending on people's human resources and depending on health system resources in a given setting. We can talk more about that. One of the challenges to integrating mental health and HIV care in many settings is that there just really aren't that many mental health workers. And a big part of integration is thinking about how do we deploy the expertise in mental health in ways that make sense. These are data from the World Health Organization. The Mental Health Atlas from 2020, just reminding us that globally, there are only about 13 mental health workers of all kinds per 100,000 people. And you can see the tremendous disparities by country income groups, where low-income countries may have as few as one, just over one mental health worker for 100,000 people. We get up to 4 in lower middle income countries and maybe 15 in upper middle income countries. But in high income countries, perhaps the median is around 62 per 100,000 population. So a lot of the conversation has been in this community of people integrating care has been, well, this doesn't mean integrating a psychologist or a psychiatrist or a psychiatric social worker necessarily to a team, but it does mean thinking about who can be trained to deliver evidence-based mental health interventions that can actually extend the mental health provider workforce. I would say as a result of this focus on task shifting, many of the kinds of mental health interventions that have been tested have been psychological interventions. And that's often because of the barriers for delivering or prescribing medications in many countries. There are very few people who have those privileges to prescribe, yet training people to deliver evidence-based psychological interventions that we know are as effective often as antidepressants are for reducing symptoms of depression is a place to start. And this is just a list of the interventions that are included in the World Health Organization's MHGAP, Mental Health Gap Action Program, as well as others that we identified in the UNAIDS and WHO manual, for which there is evidence and which have been applied to communities and individuals living with HIV. So behavior activation, relaxation training, problem-solving treatment, cognitive behavioral therapy. You can see a lot of these are elements of cognitive behavioral therapy. And I'll skip to the bottom, the common elements treatment approach, which was developed by colleagues here at Hopkins in our department, as well as colleagues at University of Washington. And this is a transdiagnostic intervention that was designed specifically to be deployed in settings where you don't have specialists, so meant to be deployed and delivered by community health workers and other kinds of non-specialists, and has now begun to be used in quite a number of settings within HIV care. I'm just gonna look at my watch. So you might ask the question about how these treatments work cross-culturally. Are these interventions appropriate for the many settings in which they have been deployed? I think it's a very important question, and it's been a very meaningful question for those of us working in this field, ensuring that the interventions that are being utilized are being properly adapted for the settings in which they are deployed. What's interesting and what has not been explored a lot is broadly whether the explanatory models of, for example, depression that these evidence-based treatments from high-income countries are based on, are the explanatory models culturally applicable? And specifically in this example, this study from South Africa, the question was whether the cognitive and behavioral constructs are actually associated with key changes in depression and other key outcomes like functioning and quality of life. So Anderson and colleagues looked at cognitive behavioral therapies, which do show effectiveness cross-culturally in many countries. And they asked, what are the cognitive or behavioral constructs that are most important for understanding and treating depression among people living with HIV in South Africa? And what they found was that the behavioral activation component specifically was associated with the reduction of depressive symptoms, improved quality of life, and reduced functional impairment. And they concluded that behavioral activation may be a particular treatment value in this context. So I think these are the kinds of studies that are quite helpful because, yes, we have an evidence-based intervention, but can we even optimize the effectiveness of that by looking at what elements may be most salient in a given context? Ethel Nachimuli-Mpungu, also was a Hopkins alum who's in Uganda, did a led a wonderful recent narrative review of the literature around psychological interventions for people living with HIV in low and middle income countries specifically. In the review, the authors examined cognitive behavioral therapy interventions, problem-solving therapy, psychosocial support groups, mindfulness-based interventions, rational emotive behavioral therapy for alcohol use, as well as brief alcohol interventions. And they looked to see where the intervention effects happened. And what they found was that they asked whether or not provider qualifications were important. Was the delivery approach important? Are these delivered to individuals? Are these group interventions? What about the caseload per provider? How about the number of treatment sessions that were attended, adherence to the treatment, as well as active ingredients of the intervention? What are the key components of the intervention? And what they found was that significant intervention effects were associated with caseload per provider for psychological interventions. The approach used and provider qualifications were not associated with the intervention effectiveness, so it didn't matter whether the person was a community health worker or a nurse, for example. Adherence to treatment was associated with significant treatment effects, but that relationship didn't attain statistical significance. They also found that studies with more significant effects were more likely to have 3 or more active ingredients within the interventions. And the active ingredients associated with intervention effectiveness were cognitive restructuring, positive coping skills, venting or sharing personal problems, and as well as social support and behavior activation. So I'm going to just talk briefly about 3 examples of studies that have integrated HIV and mental health in 3 different countries. These all happen to be on the African continent. And then we'll talk about some of the lessons learned from this research. So Brian Pence and colleagues have been working in Malawi for quite some time. Melissa Stockton led this paper. And this is a study of integrating depression and HIV treatment in Malawi. So the intervention was depression screening and treatment in HIV care. People in care were screened with the PHQ-9, and ART providers, antiretroviral therapy providers, triaged patients based on their PHQ-9 scores. So a mild to moderate score, people were allocated to receive the friendship bench. And some of you may be familiar with the friendship bench. This is a therapy based on problem-solving therapy that was developed in Zimbabwe and has been quite effective in reducing symptoms of depression, anxiety in community members. It's been delivered at community-based clinics in Zimbabwe, and now it's being taken up in many other countries, including the United States. So mild to moderate were referred to the friendship bench for structured problem-solving therapy delivered by a lay health worker or a research therapist. People with more severe symptoms were allocated to receive antidepressants, fluoxetine or amitriptyline, which was delivered by a medical clinician. What they found was that there was good uptake of the PHQ-9 screening. About 96% of consented patients received the PHQ-9. 19% had mild symptoms. Around 6% had severe symptoms. About 42% of patients referred to the friendship bench attended 3 or more sessions. Around 31% of patients referred to the medication arm received 3 or more months of medications or of treatment. What they found, somewhat disappointingly, was that there was no difference in mental health or HIV outcomes in these groups. So we've often felt, I hoped that treating depression would then also lead to better outcomes for adherence to care, perhaps even reduce viral load, and that has been seen in some studies. But in this case, there was no difference in mental health or HIV outcomes. And we'll talk a little bit about what this group believes was responsible for this. They have a really nice process paper that kind of walks through. So what happened in this study, and what were some of the barriers to seeing the implementation optimized? but we'll come back to that. The second example is not a randomized trial. This is really a convenient study in a real-world HIV care setting. And this is the delivery of the Common Elements Treatment Approach, or CETA, in Mozambique. This is work that was done with ITEC Mozambique, which is one of the many countries that ITEC, the group that I used to lead, works in, and with Health Alliance International, which has since become a local independent Mozambique organization. But these two organizations partnered with the Ministry of Health to deliver the Common Elements Treatment Approach in real-world HIV clinics in Mozambique. This initial work was done in one province of Mozambique. 16 lay counselors were trained to deliver CETA. They were assigned newly diagnosed people living with HIV. They had a caseload of 5 to 10 patients each, and they were provided clinical supervision by CETA experts who were not a part of the health system. Over the course of this study, they identified 382 people with mental health symptoms. That was 47% of the people screened. And what they found was that after being exposed to up to 5 sessions of CETA, symptom scores decreased by 74%. All patients in the study reduced their scores by at least 50%, and the number of sessions was associated with a greater odds of this having a greater than 50% score reduction. What they also noted with this population was that there was quite a significant level of exposure to trauma. Around 12% of this population were people who had active suicidal ideation. But the other good news is that over the course of this intervention, they reduced suicidal ideation to 0%. And as a result of this initial study, PEPFAR decided to fund the implementation and scale-up of CETA across Mozambique in HIV care, and that process continues with the ITEC team in Mozambique. The last example I'm going to give before moving to the next phase is around I would say that this is the most rigorous study of an HIV and mental health intervention among adolescents living with HIV in the African continent that I'm aware of. And this was a study in Zimbabwe working with an organization called Zvandiri that has been supporting peer counseling, so training youth living with HIV to provide a package of support and counseling, one-on-one kind of follow-up for young people living with HIV. And they're called CATS, C-A-T, and I'm blanking on the acronym, but this Zvandiri peer counseling intervention has been very successful in helping adolescents to adhere to HIV care and to have better outcomes with respect to viral suppression. But peer counseling alone, they found in an earlier study, actually really did nothing for people with symptoms of depression or anxiety. So this study was designed to say, if we can compare our routine peer counseling approach, but also now train peer counselors in problem-solving therapy. This is Zimbabwe, so problem-solving therapy is quite popular. So they trained a group of peer counselors in problem-solving therapy. The trial studied 842 adolescents. The majority were women. Around half of them were orphaned of one parent. The primary outcome was actually viral non-suppression. So they were looking to see what viral non-suppression looked like. And non-suppression decreased in both arms, but there was no significant difference. Mental health status was a secondary outcome. And this was the really important finding, that training of the peer counselors in problem-solving therapy, so a structured evidence-based mental health intervention, led to significant decreases in symptoms of distress, both using the Shona Symptom Questionnaire, which measures distress, and using the PHQ-9. So significant difference between the mean scores across the two groups. So that's very encouraging. And what we're learning from these experiences of pilot trials and larger studies that are helping us to understand should we think about integrating mental health interventions into HIV care. So that first of all, the interventions have to be socially valid. They have to be contextualized and adapted to the context. I think people have actually been doing a pretty good job of that in this field, because many of these, as the examples of the Friendship Bench and Shvandiri, are interventions that emerge from those settings. They're not interventions coming from North America or Europe to African settings. So there's a lot of innovation happening in many parts of the world, in particular in places where HIV prevalence is high. Adequate human resources, task sharing can help. Figuring out who is going to deliver these interventions is key, and then training those people to deliver the interventions, recognizing that often lay providers may be more acceptable than referring people somewhere else. We need to learn more about the frequency of visits and how to manage attrition from care. In the Mozambique study, people attended around 5 sessions, but CETA can go up to 12 sessions. But what they found was that at 5 sessions, most people showed those significant reductions. And it's likely that people self-selected and decided, I'm feeling better, I don't need to go back for care. But I think it's also heartening in places where people are busy. HIV care is no longer, people don't go to HIV care on a weekly basis. Often people don't go on a monthly basis. The idea now is to have more differentiated service delivery where you have fewer encounters with the clinic. So getting folks to come to a clinic visit when they really don't have to come for their medical care can be challenging. So I think the good news is that often one may need fewer sessions than an entire intervention lays out. I think the other challenge, though, is still there were a significant number of people in the Mozambique study who did drop out of care, and how do you keep people engaged? Similarly, in the study in Malawi, a number of people dropped out of care. You saw that only 30% were getting the medications, and a small percentage were actually completing more than 3 sessions of the Friendship Bench intervention. Referral pathways are essential because when folks have more severe illnesses, need more intensive care, there has to be a referral pathway from HIV services to mental health services. In the context of task shifting, there must be ongoing coaching and supervision so that people maintain their skills and quality care is delivered. When medications are being prescribed as part of treatment, medications have to be available. You can't have stockouts, and that can also be a limitation in some settings. Another issue is that HIV services have amazing electronic medical records, and those records often do not include a place for people to comment on mental health status. In some countries they do, but it's not necessarily widespread. And so adapting the health information system so that when clinicians are delivering mental health services, they aren't using handwritten records, but they can actually include these as part of the health information system, that simply enables services to be delivered more smoothly. And finally, providing the providers with emotional support through routine supervision is important when people have had pretty abbreviated training to deliver mental health services. Understanding the kinds of experiences they may vicariously have, and getting the support for working with people who often have had quite serious adversity is very important. So let me check the time. I'm going to quickly talk about the study that we're doing now in Kenya, which is around integrating a transdiagnostic psychological intervention for adolescents and youth with HIV. I'll go through these quickly. We're focusing on adolescents and youth. Just a reminder that the last UNAIDS HIV update showed that 63% of new infections in sub-Saharan Africa in 2022 were among adolescent girls and women. Adolescent girls have consistently been a group vulnerable to HIV infection. And this little diagram is just reminding us that in adolescence, this is the same time when gender norms often reinforce inequality that adolescent girls may disproportionately experience. At the same time, this is also the time that adolescents and girls in particular are beginning to experience a higher incidence of depression. And the intersection of these can lead to difficulty negotiating safer sex, as well as to vulnerability to coercive sexual experiences. What we know from the literature, this is literature on HIV and mental health, specifically the prevalence of mental disorders among adolescents living with HIV in the African context specifically. So you're seeing this 2021 study showing any psychiatric disorder, 25% prevalence, anxiety, 26%. I'm not going to read all of these, but the takeaway is that the prevalence is high. This smaller table is of a smaller number of studies that have actually looked at the differences in prevalence by HIV status. And with some exceptions where this first study, it's fairly equal, the prevalence among people living with HIV and without. The other studies show a much higher prevalence of depression among people living with HIV. So let me go to Kenya. This is Kenya on the east coast of Africa. Kenya has a population of around 52 to 53 million people, has about 115 psychiatrists, about 460 mental health nurses, a large number of psychologists, but psychologists who may be at a bachelor's level, may or may not be delivering clinical services, and no data for child and adolescent providers. A very recent study that looked at the prevalence of mental health conditions among adolescents in Kenya has found that a 12-month prevalence of any mental disorder among adolescents is around 12%. Kenya is a country that's quite motivated to address mental health needs. This has been central for both the president as well as the Ministry of Health. And Kenya published its mental health action plan 2021 to 2025 not long ago. And I'm just going to highlight this last little square, which may not be that legible, but essentially it emphasizes the importance of integrating mental health care at primary care, integrating mental health care with HIV services and other programs, and establishing peer support groups and community care coordination networks. So the gaps that we are looking to fill in our study are what the Presidential Task Force on Mental Health in Kenya found: deficiencies in mental health care competency among providers, and the need to make mental health care more available in primary health care settings, noting that specialist care right now tends to be concentrated in large facilities. The other service needs are that we noted that most HIV services are offered, of course, by non-mental health providers. These are medical officers, clinical officers, nursing officers, and counselors. Peer educators play a major role in care, especially in treatment support. So these are the resources available. How can these folks be equipped to deliver mental health services? And finally, school-going youth attending boarding school make up around 20% of adolescents and young adults living with HIV, and they have discontinuity in care because they are typically away from their primary service providers for a good chunk of the year. So thinking about how these young people can also access mental health care is important. I want to note that the work that we're doing in Kenya is based on decades of relationships between University of Washington and University of Nairobi. I was at University of Washington when we submitted this grant. Our work has involved collaboration with the World Health Organization, with the Kenya Ministry of Health, and with the Nairobi Metropolitan Mental Health Unit. And now in our current study, which is working across 3 cities in Kenya, we're working with the county health units in all of those places. It also is built on a long experience of testing evidence-based psychological interventions in Western Kenya in particular among adolescents. My colleague Shannon Dorsey at University of Washington has been leading a lot of this work, and my colleague Muthoni Mathai, who is at University of Nairobi, has also been leading rigorous studies of interpersonal psychotherapy and other psychological interventions with people vulnerable to and living with HIV in Kenya. Quickly, we did some preliminary work. I'll talk about the preliminary work I've been involved in specifically that focused on how do we ensure quality care through training non-specialists. This is just reminding us that task shifting is one of the models for equipping non-specialists to deliver care, and task shifting can include people living with HIV, it can include other peers, community health workers, but could also mean using primary care doctors or other non-physician clinicians. So there is a variety of people who can be engaged in task shifting, but essentially it means providing abbreviated training of less specialized health workers and ensuring that those people who have an abbreviated training are set up for success and set up to deliver quality work. One of the workforce packages that the World Health Organization has been developing to support this, to say, how do we ensure that if we're training all of these non-specialists to deliver psychological interventions in particular, how do we ensure that they have the competencies required? So our team was part of a global network working with WHO, working with colleagues at George Washington University. Brandon Court was leading this work there to say, let's test a program of competency assessment and competency-based training to see how people can deliver the evidence-based interventions that they've already been working with in these different countries, and what does this mean for the training of non-specialists. So the EQUIP program, which stands for Ensuring Quality in Psychological Interventions, uses a tool called ENACT, which is based on the typical observed structured clinical evaluation approach to training specialists. Anybody who's taken their psychiatry boards has been through this kind of evaluation, but most countries use this kind of approach for training specialists. And so the idea is to say, how do we identify a set of core competencies? And this is what the ENACT tool looks like. It's an online tool that you can rate the competency of a provider when you're watching them do a role play. But it's saying, how do we use this to rate competencies, train people according to the competencies that they are less proficient in, and see where we end up with respect to the care that's delivered to beneficiaries. Our team was using trauma-focused CBT because this is what we have been doing in Kenya, the larger team, for the last decade or so, and using the apprenticeship model, which says in order to train non-specialists, you first do a very active, interactive, in-person training with role plays. We learned that this could be done virtually because we had to make that shift during COVID. But after the training, what happens next is most important. It's structuring supervision groups with people who've just been trained. They have a couple of weeks of supervision without seeing any patients. They then get a practice client, and again, weekly supervision before they are approved to receive their first client. The person has to have shown that they're functioning adequately, and the EQUIP tool, the ENACT tool, actually helps you to, again, measure specific competencies, which can be used to gauge when someone's ready to receive the next patient. And this is just an example of when we were doing these competency assessments in our first study. So our first study, our pilot study in Nairobi, was training community health volunteers and psychologists who worked for Nairobi County in trauma-focused CBT using this competency-based approach. Our second training said, well, let's expand. We were expanding the number of community health volunteers trained now in key modules of TFCBT. Because this happened during COVID, we had to switch the training to JITSI. The training was provided by a group of therapists from Western Kenya that our team has been working with for many years. Supervision was delivered via telephone, and therapy with a group of adolescents was developed via telephone and, when safe, in person. This just gives you an example of the total youth sample that we had. We recruited 89 people, recruited and screened. The majority of these folks were not eligible to participate, either because they needed to be referred because of more severe symptoms, they did not have any depressive symptoms, or they were not interested. But we ended up with a smaller group of youth who did go through therapy. And I'm just going to do this quickly. For those who participated in the therapy, when we examined their outcomes with the revised childhood anxiety and depression scores, depression scale and anxiety scale, we saw mean reductions of scores pre and post, non-significant reduction of mean scores pre and post with a PHQ-9. Again, this is using a TFCBT-derived intervention. So our current study takes these elements of TFCBT, psychoeducation, relaxation, problem-solving, behavioral activation, and cognitive coping, to be delivered one-on-one or by telephone through trained providers in HIV clinics to adolescents and youth 16 to 24 years old with psychological distress through 4 or 5 sessions with a 30 to 45-minute session. The plan is for weekly sessions, and we'll look at depression and anxiety outcomes in particular. This is just a sense of what the study design looks like. We have recruited 30 clinics. 15 clinics will receive the intervention arm, which is the psychological intervention. 15 clinics will do what they usually do for managing adolescents and young adults who have depressive symptoms after they screen. And we'll train providers, 2 to 3 providers in each of the intervention clinics to deliver the brief TFCBT-derived intervention. And we aim to enroll around 300 adolescents and young adults living with HIV in both intervention and control groups. And these folks will be followed over the course of 12 months with 3, 6, and 9-month interventions. And of course, with a plan for referral to specialist care for people with severe symptoms. Where are we now? We've had a wonderful stakeholder workshop in November, bringing together people from the National AIDS, NASCOP, which is the National AIDS group, young people living with HIV, practitioners, both mental health providers and mental health, HIV providers and mental health providers, AIDS and sexually transmitted infection coordinators and mental health leads at the county level, implementing partners, so on, along a key group of people to really talk about what do you think of the content? Does this match the needs that you see in the clinic? Let's develop a model for training and supervision that's going to work in an HIV clinic. Who should deliver this? Is it going to be an adherence counselor? Is it going to be the peers? Is it going to be someone else? Who's the best person to deliver this intervention in this particular setting? Is the delivery going to be in person, by telephone, during routine visits or outside of those visits? And what are the inclusion criteria for the young people and referral procedures? So we had a wonderful meeting to discuss these. At this point, we have moved to training of our providers, our PROACT providers at each of these clinical settings, finalizing the baseline package for assessments, and we'll be moving forward with recruitment shortly. So I presented a lot of information about what we know has worked and what have been some of the challenges in the past for integrating HIV and mental health. And I told you a little bit about a randomized controlled trial. It's an effectiveness study. It's a hybrid study because we're also looking at a lot of implementation outcomes as well, because we want to learn from this process. And we're early on, we have no results, but this is what we're working on. And I look forward to being able to come back and talk to you once we have some more findings. So I'm going to pause here to see if there are any questions in the remaining time that we have. But I also want to acknowledge all of my colleagues with Equip Nairobi, our pilot study, the PROACT trial, and our funders, USAID and IMH, the Rural India Social Trust. And let me stop sharing so I can see who's out there.
Thank you, Pamela. Wow. I just have so much admiration for the work that you're doing and have done. It's, I think all of us work with vulnerable populations, but boy, HIV and mental health combined is an extremely vulnerable set of people. And when you add on all the logistical challenges of working on another continent, it's so impressive that what you continue to do. We don't have much time. Let me ask you this. You talked a lot about psychological interventions, and of course that makes an enormous amount of sense to focus on psychological interventions. An awful lot of the people I think who've been watching are psychiatrists. Not all of them are, but a lot of psychiatrists here. What would you say to a psychiatrist who wanted to be involved in this kind of work?
I think one of the approaches that certainly has a tremendous evidence base in the United States and has a growing evidence base in other countries, and particularly in Africa and Asia, is the collaborative care model, right? Where the psychiatrist is really the consultant who is not present, who's not delivering the services, but is there to support the team, the primary care providers, and the care coordinators who are delivering the services. So I think that's in countries where there just aren't enough psychiatrists to do this kind of work, and you don't have a psychiatrist who's in an HIV clinic for the most part. I think models like that, where the psychiatrist really gets to be the backstop, the person that's saying, hey, okay, those folks whose PHQ-9s aren't changing, let's think about what are you doing? Let's think about a treatment plan. How can you adjust? So I think in a stepped care, collaborative care model, there's certainly a role for psychiatrists. But we're trying to say, how do we get HIV, how do we get this care delivered in HIV settings? Because what we find, the real issue of what we find is that when people are referred, they don't necessarily go, you know. If you screen somebody and you say, okay, go see the psychiatrist, they may not. So having co-located care that fits with the model. But you know, we're still working this out. I think it's beneficial to have people who have the time and the space to deliver mental health services in these settings. So figuring out who that person is, I think, is an ongoing challenge for each setting. Any other questions in the last minute? Oh, you're muted.
Sorry, how did I mute myself? Sorry about that. Geetha Jairam says, what recommendations do you have for this country that has similar problems that is sixfold and minority groups are unable to access care?
Yeah, that's a great question as well. I mean, I think people in this country also, you know, are beginning to say, can all of this work we've been doing with task shifting be utilized here? When I was leaving Washington State, the state of Washington is actually now, my colleagues at UW, our psychiatry department was exploring this possibility of a bachelor's level person to deliver psychological interventions, and they received startup funding from a foundation, have been working with the state level accreditation to say, well, can we get a person like this accredited, and why not? So figuring out how we can train people to deliver these interventions and actually pay them a decent wage, I think is one step that we can take in this country.
Great, thank you. We'll have to wrap up, but that is fascinating work, and I suspect you'll hear from some of the folks with looking into what kind of opportunities exist in your department along these lines. All right,
Yes.
thanks.
Come visit us. Thanks so much.
Thanks for tuning in, folks. Have a good week.
Bye-bye.